Over the next few conversations, we are going to take a deep dive into the role of innovation in combating diseases that are both old and new, rare illnesses and how they've become a research priority, and biosimilars in the American marketplace. But first, it's time to hear from a man who has been at the forefront of trying to solve some of the most vexing challenges in healthcare. I am delighted and honored to welcome Dr. Zeke Emanuel, the Vice Provost of Global Initiatives and Chair of the Department of Medical Ethics and Policy Health at the University of Pennsylvania. Joining him on stage is the Hill's Editor-in-Chief, Bob Cusack. So over to you both.
Thanks for joining us, Doctor. I want to start. You were involved in the Affordable Care Act, and politics has become very partisan now, especially healthcare. There's always a lot of noise about healthcare.
Wait a second. I'm Dr. Death. You're telling me it's become partisan? It was partisan, and it always has been partisan.
And will it always be partisan?
Yes.
And is there any...
Until the Democrats rule the whole country, it's always going to be partisan.
Will you be watching the debates tonight? Healthcare will be a top issue.
It will. That no doubt about it.
But you are not. You're not a fan of Medicare for all.
Correct.
Why is that?
Well, I think that it's mostly a political reason. If you look at history, we have tried to get a single-payer system where the government funds it in the United States. It would definitely be simpler. And complexity is one of the real bugaboos of the American healthcare system. But I think politically, it shows that it's not going to, it's almost impossible to get. First of all, Americans like the idea in theory, but not in practice. They don't want to give up their private insurance. And second, and I think more importantly, the private health insurance industry is now a $1 trillion industry in the United States. I don't know of any country that has put a $1 trillion industry out of business. They will fight with, it's an existential threat to them. They will fight with everything they have. And rather than spend a lot of time, all right, how do we get to Medicare for all? I think we need to think of spend our time more fruitfully thinking of other solutions to the problem, the underperforming problem of the American healthcare system, where our quality is, comparatively low and our costs are too high.
And do you think even if Democrats won the White House and control of both chambers of Congress, that Medicare for all could even pass?
I was there in 2009 and 2010. We had that scenario, and we had 60 votes in the Senate, and it wasn't going to happen.
And you couldn't get a public option at that time because you didn't have the votes.
Democrats are a very capacious party with lots of different views, and even wrangling all of them is a challenge.
Well, you mentioned that you were one of the architects of the Affordable Care Act.
I didn't mention that. You did.
Okay. Well, you were. Speaker Pelosi and other Democrats have said we shouldn't do Medicare for all. We should shore up the Affordable Care Act. What needs to be fixed?
Well, look, it's passed 9 years and 3 months ago. So anytime you have something in place that long, it needs adjustment. And because of political paralysis in Washington, we haven't had adjustments. There's no corporation, there's no public body that would pass a major change without modifications and mid-course corrections. In Massachusetts, when they passed their Romney Care and basically created an exchange and got 96-97% of the population covered, they had multiple revisions and adjustments. And same thing, you got a 906-page bill. There are many things that went right, many things that went wrong, many things that we need to make adjustments to. If you want to say, look, coverage has expanded by 22 million people. We still have 28, 30 million, to pick your number, uninsured. There are things we can do to solve that problem. In my view, the thing we have to do is try to get as close as possible to auto-enrollment. That is, someone doesn't have to initiate something, someone doesn't have to pay a premium to get health care coverage. It would require adjustments in the law. That's one thing we have to do. I think there are some things in the exchanges that we can do to make things better. One of them, obviously, is increase subsidies. Another one of them is to change how we determine the income. I mean, very technical change, very simple change to make it identical to Medicaid would actually make a big difference in terms of getting more people covered. So I think that we need auto enrollment, and we need to do a lot of the technical things that make auto enrollment possible, so that people, they show up at the doctor, they show up at the hospital, and they have coverage, and we'll figure out how to get that bill paid. That's every country that gets a 99, 100% coverage does auto enrollment. We do it in Medicaid for the hospital part of the portion where there's no premium, and we need to figure out how to do it more broadly in healthcare.
You mentioned other countries. What other countries are a good model for the United States to learn from?
I'm just finishing a book on that entitled, Which Country Has the World's Best Healthcare System? And all countries, first thing to know, are complicated. Not as complicated as the United States, but they're complicated. We are doing some things fantastically well in the U.S., and I would put at the top innovation in payment and innovation in delivery. We are trying lots of new systems in how we pay doctors and also and hospitals, and how we deliver care to improve the quality and improve costs. That innovation happening throughout the system, some of it by the government, some of it in the private sector, I think is why I'm optimistic over the next decade we're actually going to substantially improve the healthcare system. But there are lots of things like this auto enrollment, bringing down some of the complexity in the system that we can learn from other countries. I will say another thing that I'm a big fan of, covering children. Right now, in the private sector, individual coverage at an employer is about $5,000–$6,000. A family coverage is $19,000 to $20,000, and that worker has to pay for the kids on their plan. You go to the Netherlands, you go to Switzerland, you go to Germany, you go to other countries, and the government pays for kids. So it's not an additional burden on the family to pay for their health insurance, which, as we all know, is quite expensive. So if the government paid for every kid up to 18, I think that would make a huge difference, and it's an innovation that we ought to have in this country if we really believe giving every kid an equal start in life.
Do other countries have the employer model? Because basically in this country, with obviously exceptions, if you have a job, you have health care. If you don't, you don't. And that doesn't really make any sense.
Yeah, that's a little overly simplistic, but a lot of other countries, health insurance is related to a job. It's not quite the way we do it. Germany has a system where the employer and the employee pay into a central fund, and then that central fund then pays the insurance company that the worker has chosen. So you do have an employer-based system in many countries. It's not as complicated as ours. I mean, you know, one of the things you learn from going all over the world is the United States has every kind of healthcare system right here in one country. We have socialized medicine, thank you VA, right? We have single payer, thank you Medicare, right? We have single payer with a lot of private sector, private insurance contribution, thank you Medicare again. We have employer-sponsored insurance. So we have all the different ways of financing healthcare right here in the United States. That's one of the complexities, and it makes it hard for people to figure out where they are, which doctor they can use, how much they owe. That's much simpler in every other country.
What do you advise young professionals who are looking to get into the medical field?
What do still a great field. I still think it's wonderful. You know, you can care for people, you can make a difference in people's lives, and you can make a difference if you're inclined to change the system. You can make a difference in changing the system.
But the system also requires a lot of money. I mean, these schools are very expensive, and loans.
Medical schools?
Yeah.
Oh, yeah. Look, the medical schools are the average medical student graduating college, graduating med school is $190,000 in debt. Only 15% of graduates have no debt. That turns out to be a trivial problem if we had the will to solve it. And I'll just give you the numbers. We have 80,000 medical students, right, every year. To fully fund them, right, is not a lot of money in the scheme of things. It's about $10 billion. You could give it as forgivable loans. So we're going to pay your med school. You go into primary care. You go to underserved parts of the country, whether it's rural North Dakota or it's the inner city. You do those things, we're going to forgive your loans, just like the military does for its doctors. You, on the other hand, decide you want to be an orthopedic surgeon and make $1 million a year. You want to be a urologist and make $2 million a year. You have to pay back that loan with interest. It's that simple. And it would be after a few years, it would, probably pay for a good portion of itself. And in a $3.5 trillion economy, a few $1 billion is not a lot of money. I think we need to move to that direction.
How would you grade the Trump administration on health care?
Totally confused. I mean, look, I was asked to advise him. I went in before he took the oath of office. After he took the oath of office, I told him, there are things you can do to, go down in the history books as really solving healthcare problems that even President Obama couldn't solve. Tackle the drug cost issue, make it more affordable, focus on that issue. Instead, we got, repeal and replace. I told him that was going to be a failure. He would never get repeal and replace, and he hasn't gotten repeal and replace. I will say that there are some things they're doing that I am quite supportive of. If you look at CMMI, that's the Center for Medicare and Medicaid Innovation, something we created in the ACA. They are doing a lot of innovating, and I think a lot of this payment change and delivery innovation, and I think that's a very important, necessary part. But look at drugs. We've gotten, I think, only confusing statements. Last October, we're going to have an international price index. No one's heard hide nor hair of that, or whether it's going to happen or not happen. There's no consistency, and if I read your journal and other journals correctly, there's a lot of battle between HHS and the White House, and some disagreement and some working out of policy is good, but constant fighting on every policy with no clear positive direction, where the positive direction is we've got a policy to get more people covered and we've got a policy to bring costs down. We have a problem. And I have yet to hear a Republican plan to get 28 million people covered, or a plan that actually has any plausibility of bringing healthcare costs down.
Do you think the administration has administered the Affordable Care Act in good faith?
No.
In what way?
I mean, they've tried to undermine the idea that you have to have insurance. They've obviously repealed the mandate, but they are also, all these association plans and all these other efforts are trying to undermine the 10 essential benefits that we put into the plan and having people get real health insurance that isn't mini Mac plans that don't really cover when people get sick. And you constantly heard, we should not make men cover maternity care. Right? We should not cover mental health care in the middle of an opioid crisis. I mean, those are like crazy policies. Last I looked, there's no pregnancy in the world except one where a man wasn't involved. Just simple facts of life. And the second thing is, you're in the middle of an opioid crisis. Everyone in the healthcare system now recognizes the essential problem of mental health, that it's been underdiagnosed, undertreated, and you're going to get rid of that benefit just when we've recognized that benefit? Oh, and let's not cover dental care or vision care for children. I mean, those are not coherent policies that really are aimed at improving the health of the population in the United States.
What has been the effect of the elimination of the individual mandate?
Well, we've seen an uptick in the number of people without health insurance. It's just, you want to do that, you can achieve that. Yes, they have proven that.
And that's the direct cause, you think?
Oh, absolutely. Okay. You look, the uninsured rate goes down to 2017 and then has been ticking up since Trump took office.
Should marijuana be legal?
It's not my area of expertise. I am quite skeptical that we know the full effects, positive and negative, on it. I think it's a big experiment without a well-controlled effort. So, I like to have data before I make big policy adjustments in this country. Would be my main conclusion there. I will say one thing. I think this idea of medical marijuana, I do not like that. That is just a fig leaf and puts doctors in a terrible spot. It's a fig leaf for people to use marijuana and puts doctors in the spot of, sort of lying about whether they really need marijuana. There's not a ton of evidence it makes a big difference for things like epilepsy or other issues. I mean, if you want to legalize it, legalize it. Don't make it medical marijuana. Just, bite the bullet and say what you're doing.
What are the biggest challenges 10, 20, 30 years out in the looking forward to healthcare?
The biggest challenge today is going to be the biggest challenge 10, 20, 30 years out, and that's healthcare costs. It's just that simple. We spend a lot. Every other country you go to They're also worried about healthcare costs because of the aging of the population, multiple chronic conditions, and we have to figure out a better way to deliver care, to keep people healthier, to use lower cost services, to control drug prices in this country, to control hospital prices in this country. So that's one area, and I would say a second area we're going to see big time, and we're not prepared for it, is long-term care in this country. We're going to double the number of elderly people over the next 3 decades or so. Long-term care is a big problem. We don't have, in point of fact, long-term care insurance has gone down. Medicaid is the main payer for nursing homes, and that's for people who are of very low income. And I think we're going to have rude surprises for a lot of people who are going to care for their parents who are living longer and longer, and it's just going to put a real squeeze on people. And if you ask, well, why is the birth rate going down? We ask people to pay for the health care of their children. Daycare is very expensive. Now you're going to be spending a lot of time caring for your parents, and it's like, well, you know, it's no surprise that this mix of problems puts a real strain on people's time, and one of the consequences is, I think, you know, you got a lower birth rate, and people are feeling very, very squeezed financially, but also in terms of their time allocation.
One of the things Republicans say for long-term care are health savings accounts, but of course critics say no one has a disposable, or very few people have the disposable income to actually take.
Do you know what long-term care costs?
It's a lot.
A lot is not a number. Yes. It's about $50,000 per year, right? Now just multiply that out and what you need to save going forward. It is a very, and if you were say to young people, save for that, right? I mean, I'm paying off my college loans. I can't put money on a down payment, right? I want to have kids, and the costs of having kids are very expensive. And you want me to save for long-term care? This equation just doesn't compute.
So does.
And by the way, there are other countries like Germany and the Netherlands are two in particular that have created a long-term care tax facing and recognizing this problem. A lot of countries are like us. They're not prepared for the problem, and they're scrambling.
I want to open for audience questions. If you have a question, please raise your hand and wait for the microphone to get to you, and hopefully we can get a few in. And if you can identify where you're representing over there.
Is this on? Oh, okay. I'm Susan Harford, and I'm with Marketing Bank. And I read your book when it came out with the ACA. And one of the things that I thought was really interesting was you said one of the great benefits is going to be the data that comes as a result of what the ACA is asking for. And, you know, today data has come up tremendously and seems to be powering a lot of innovation. Is this what you were thinking of, and has it come as far as you wanted?
Well, nothing's ever come as far as I wanted. I'm a very impatient person. And I don't know that I said data was the most central thing. I do think data is, it's one of them. I do think data is important. What we have now is a great deal of difficulty. There are lots of companies in the space, and a great deal of difficulty of aggregating the data, making it understandable, putting it in a common format, and that turns out to still be a problem. I do a lot of research, and we're still heavily reliant on claims data rather than electronic health records data. The electronic health records isn't in a format that is easily digitized, and one consequence is, you know, lots of people are working on natural language processing, et cetera, and it turns out to be much harder than you think. I think we're still a good decade or more away from having a unified digital source. On the other hand, I was just talking with Dr. Zerhouni. There's $1 trillion, maybe $2 or $3 trillion companies out there that if you can put the data together, then I do think that there's going to be a lot of insights. But I think it's going to take a lot longer than we think. And I think everyone telling you, you know, I've got the solution, it's in the data, I wouldn't invest your life savings in that company just yet.
Time for one more.
Thank you. My name is Lauren Lukey, and I am with MJT Policy. So my question to you is, first things first, I think you might have lowballed the long-term care expenses. I think
I didn't say nursing home. I was combining all of them to give you an average. Nursing homes are about 90,000, and home care is a little less.
If you have government subsidy with home care, otherwise it can be $10,000 to $12,000 a month if it's completely out of pocket. And my question to you is, what would your solution ideally be for a long-term care policy for the United States?
Well, I think there's, it's a money problem, and I don't think that you can't get to the tens of billions or hundreds of billions of dollars we need without some collective effort. Collective effort is a euphemism for taxes. So if you want to solve that problem, I think we're going to have a program that is funded. But I am not optimistic about it, and let me tell you why. We had a very difficult time persuading people to pay for health insurance, which everyone, whether you're young or old, you can anticipate you're using. Now you're going to ask young people to pay for care for older people at past 65 or whenever, 40 years down the line, when, as I said, they're trying to do all these other things, pay off their student loans, put a down payment on a house, pay for child care. And I think there's going to be a lot of skepticism of them that they should be doing that, and that tax 1.5% of employer wages or whatever kind of level we need is their top priority. I would think it's going to be way down their list of priorities, where education, child care, health care, housing are much higher on their priority list. And I agree with them. And so I think, long-term care policy, I'm not optimistic about it. I can say what we should do, but I'm not optimistic it's going to be politically feasible. And by the way, I think those other things may be, investing in our children and investing in education. They're really high priorities for a country. I think they're very high priorities. And you see, again, if you go and look at other healthcare systems around the world, they also do make trade-offs like this, investing in children versus investing in long-term care. And that's a debate we have to have in this country. We don't invest enough. I just make a point here. If you look at the federal budget, for every dollar spent on kids 18 and under, where, by the way, the majority, I think it's the majority, certainly the plurality is for Medicaid and health care, there's $7 spent for people over 65, each person over 65. Now, that's a philosophical decision we make. And I think, young kids, that's our future. That's what we have to invest in. And I think that is, in my view, a top priority. One of the things I would like to see is more investment in children, and one of the biggest payoff programs you can think of is early childhood interventions, especially for vulnerable kids in poverty. 40 to 50% of all children are born on Medicaid. Medicaid pays for them. Those are vulnerable kids, and giving them early childhood interventions proves to be beneficial in better health, better education, lower engagement with the criminal justice system. And I think that, if you ask me for my single top priority, that's my single top priority.
When's your book coming out?
April 2020.
Okay, great.
Look for it, yes. Thank you.
We've run out of time. Please thank the doctor for joining us this afternoon.